Started. Rafa, is that okay with you? I think you might be muted.
That's okay with me.
Okay, perfect. Okay, so welcome everybody, and thank you for joining us today for this special Grand Rounds. It is my great pleasure to introduce Dr. Rafael Alonso, who is the current director of the Toronto ACHD program, and he's our current visiting Perloff professor. And I just want to say a thank you to the Perloff family and friends of the Perloff family who have funded this visiting professorship at UCLA that we've had going now for over a decade. We had a little hiatus during the COVID pandemic where we did not have visiting professors, but it's great to get back on the horse and great to have colleagues from around the world coming to visit us again. And speaking about colleagues from around the world, Dr. Rafael Alonso, although he comes to us currently from Toronto General and the University of Toronto, where he's the director of the ACHD program and has been in that position for the past few years. He was originally born and grew up in the northwest of Spain, Galicia, and attended medical school in Pamplona, and thereafter ended up doing pulmonary hypertension training in Spain, and then going to England, to London, where he trained at the Royal Brompton Institute with Dr. Michael Goudzoulis and his fantastic, really world-leading team in ACHD. And he did a 2-year fellowship at that location, and then returned to work at the Royal Brompton before coming back to, or coming to Toronto. And after a few years in Toronto, became the director of that program. He also has trained in heart failure and transplant, and he's a recognized heart failure specialist, has received numerous awards in education. And I really want to just kind of highlight, Dr. Alonso as an educator, and really highlight something that Toronto General, the ACHD program, has been doing there that is a great resource for the entire ACHD community throughout the world, which is twice a month on Friday mornings, 8 a.m. their time, so it's 5 a.m. our time. They have an ACHD Grand Rounds where they invite speakers from around the world and cover major topics. And it's for any fellows, trainees, attendings, anyone who's really interested in learning a lot about ACHD, I would really ask you to look into this particular resource. And I know Dr. Alonso will share some of his contact information if you're interested in signing up. So without further ado, thank you, Dr. Alonso, for visiting us at UCLA. And he will be speaking to us today about heart failure in ACHD and what makes it different. So go ahead, sir.
So thank you, Jamel, for inviting me to be here today. It's a real honor to be the inviting professor for the Perloff Grand Rounds. And I just wanted to start with this picture that I met Dr. Perloff when I was a fellow, and he was the visiting professor at that time at the Royal Brompton. This is a young version of me, and he actually requested to spend an hour with the fellows at the time, and we had the a spectacular opportunity to chat with him. We sat around the table, asked questions, and it was really moving. And that was the beginning of my journey in congenital heart disease. It was really moving to see his passion and his knowledge in the field. So several years later, to be here is a real honor to be able to give these rounds. So thank you. So we're going to talk today about heart failure and congenital heart disease, and I want to start just with something that is, if it's anything we have done very well over the last years in congenital heart disease, is to reduce the mortality of patients that are born with congenital heart disease, and to the point that nowadays, majority of patients that are born with congenital heart disease, they make it to adulthood. And this has changed significantly the prevalence of congenital heart disease. And you can see these are already all data from Quebec, but still relevant today, that the number of patients with, the adult patients with congenital heart disease is already more than double of the pediatric population with congenital heart disease. Of course, if you have congenital heart disease and you live to adulthood, comes with a price to pay. So these patients are not cured and have residual conditions. And one of the risks that they have is to develop heart failure. This is a very interesting study that was published last year. I think I changed computers, and I think that the references have been screwed with changing from Mac to other species. So I'm really sorry, but this is a study published last year from a Sweden population that they look at 22,000 patients with congenital heart disease, and they follow them for 40 years, and they look at the incidence of heart failure in this population compared to the general population. And surprisingly, they found that even those with simple congenital heart disease, they have almost a 7% risk of having heart failure in their lifetime. And this was up to double in those with complex congenital heart disease, as you can see here in the graph. But what is really interesting in this study that they saw that the risk of dying if you develop heart failure in this population is up to 65%. When I was at the Bronton, we looked into our admissions in heart failure over a period of 10 years. And you can see here on the left is a graph representing patients that had had more than 2 heart failure admissions over the 2 previous years. On the right, patients that had more than 4 heart failure admissions over the 2 previous years. The different colors are the ages. And you can see for any given age, over time, the amount of admissions for heart failure has increased significantly. And in those that over 50, the increase is exponential. So it's obvious that this is a tsunami. And one of the major things that we deal with in this population nowadays is heart failure. And when you look at what caused heart failure in these patients, these are data from the Ariane Marelli group in Montreal. Some of the risk factors are no different than those that you can find in patients with acquired heart disease, like having previous heart failure or having pulmonary hypertension, having coronary artery disease, or having diabetes. And similar could happen to patients with congenital heart failure, with acquired heart disease. The more risk factors you have, the higher is your risk of developing heart failure. This is a risk score that the group from Montreal has developed, that giving certain points to each risk factor. You have more than 8 points in this score, which meaning the more risk factors you have, the higher is your risk of developing heart failure. But what happened to the prognosis of these patients? This is a very interesting study published last year in Heart it was led by Penn, and looking at the US database of patients that were seen in the emergency department with heart failure. They look at what happened with those with congenital heart disease and those with acquired heart disease. And it's not surprisingly that if you have congenital heart disease and you are seen in the ER with heart failure, you are more likely to be admitted. That's not a surprise. But if you are admitted with heart failure, you are more likely to die during the admission. And this is independent of you having a complex congenital heart disease, like a single ventricle, or having a biventricular circulation. So these patients develop heart failure and have a worse prognosis. This is not a surprise, excuse me. So because already many years ago, we learned that as our population gets older, the arrhythmias, which was the most common cause of death many years ago, become less relevant. And these are 2 significant publications already from several years ago that show that after you've reached the age of 40, the main cause of death in patients with congenital heart disease is heart failure. And this increases exponentially, as you can see here from this paper from Dr. Dillon. So we have a population that have a higher risk of developing heart failure with worse prognosis and with a significant risk of death because of heart failure. So What are the challenges? And we said that some of the risk factors or the problems are similar to acquired heart disease, but there are significant challenges in this population that makes this population different. One of them is quite obvious, is that our patients are very heterogeneous, but not only from the anatomical perspective, but also from the physiological perspective. So anatomically, although we have many patients with biventricular circulation and systemic left ventricle, we have patients that are unique in congenital heart disease, where like patients with systemic right ventricles or patients with univentricular heart. And definitely, if you do heart failure in congenital heart disease, you're going to deal more with more right ventricular failure than you normally do if you do acquired heart disease. But as I said, not only anatomically they are different, but also physiologically they are different. And we have patients that have what we call a preload dependent circulation, which is completely different management of a patient with a non-preload dependent circulation. We have patients that will present with heart failure with atypical symptoms like protein losing enteropathy. Our patients are going to have a right to left shunt and a higher risk or a higher prevalence of secondary hyperaldosteronism. So all of this makes these patients more complex to treat and more difficult to have a universal universal definition or way of treating these patients. Actually, the first thing that we don't agree is what is the definition of heart failure in congenital heart disease. Well, it's true that you come across with patients that might present with what we recognize as a cardiologist as a standard left-sided heart failure or a standard right-sided heart failure. It's more common to find patients that will present with a myriad of symptoms that might be in a specific, like fatigue or inability to work or increasing abdominal girth or more diarrhea, symptoms that unless you are alert and trained to manage these patients, you might also you might not identify as symptoms of heart failure. One of the main things with these patients, they have a reduced exercise capacity. And one test that I really like to follow patients with congenital heart disease and heart failure is the cardiopulmonary exercise test. One thing to note is that we cannot use the normal values that we use for the acquired heart disease patients, and we cannot use even the normal values for all congenital heart disease patients. As you can see here, these are data from the Brompton when I was working there. We look at the mean peak VO2 in each lesion, and you can see that it's completely different depending on you have a mild lesion like a coarctation or a severe lesion like a univentricular heart, like a fountain. So important to know which is the average peak VO2 that you expect to have in this population, but more importantly is to follow them with regular MVO2s and see whether they have a decline in objective exercise capacity, because these patients are so used to be limited that they might not have a subjective decline of exercise capacity. They are used to adapt themselves to their limitations, and they might not tell you that actually have more symptoms. So I find the CPET extremely helpful to follow up this population. We also need to be aware that the mode of presentation of heart failure can be completely different than they are in a non-congenital patients. This is a patient of mine when I was at the Brompton that he presented with increased shortness of breath and mild peripheral edema, some ascites. I don't know why the video doesn't display now. And you can see here, this is a patient with a fountain circulation. This is the univentricular heart. All of this massive thing here is a right atrium. It's a classic fountain connected to the PA. And this massive thing here is a clot. So although he presented with heart failure, of course, how we managed this was to just remove the clot, and we converted him into an extracardiac fountain. And this leads me to the next important difference in heart failure and congenital heart disease. When you have acquired heart disease patients with heart failure, the first thing that we do as a cardiologist is to treat them with medication and to modify the neurohormonal modulation that these patients have. In patients with congenital heart disease, very frequently, if they develop heart failure, the first thing we're going to do is to see what is wrong with them and what is if there is any lesion or any complications that we can treat prior to consider to give them medical therapy, which, as you can see here, is at the top of the pyramid of the management of heart failure, opposed to the base of the pyramid in patients with acquired heart disease. And this is one of the multiple algorithms that you can find in the literature of how to treat heart failure and congenital heart disease. And they only brought it here to notice that when you have somebody with congenital heart disease and heart failure, we're going to do many things like surgery or treat comorbidities or look for other reasons before considering to treat the patients with medical therapy. So medical therapy is there, but it's not the first line therapy. And why is that? Well, I always feel jealous of my colleagues that do heart failure and acquired heart disease, because it's beautiful to have the recent published guidelines with tons of medications that have proven already to increase survival and improve prognosis in this population. And you can use now all of them according with the guidelines, and you know that you are helping your population. The problem is, when you have such heterogeneous population in patients with congenital heart disease, when you give medical therapy, because physiologically they are different, it's very important to understand the physiology of the condition you have in front of you. And a very good example of this is one of my favorite papers in congenital heart disease. I came across to this paper very early in my training, and stayed with me since then, because I really think that reflects the difference in physiology in this population. This is a paper where the authors got patients with systemic right ventricle with CCTGA or LTGA, patients with master ascending with an atrial switch or DTGA repaired with atrial switch. And they gave them dobutamine, and they look how they changed the cardiac output. And they saw that they give dobutamine to these patients, and both groups were able to increase cardiac output. But when they look at how they would increase cardiac output, they saw that patients with LTGA or CCTGA were able to increase both stroke volume and heart rate. But patients with a master ascending, they were able to increase heart rate, but they definitely were not able to increase stroke volume. Why this is important is because if you have, this is what one of the examples that we call preload dependent circulation. You have a preload dependent circulation and you give an afterload reduction. You actually, if you are not able to compensate increasing stroke volume, instead of increasing cardiac output, you might be reducing cardiac output. So important to know the physiology, to know how to treat your patients. The good news is that majority of our patients are going to have a biventricular circulation with a systemic left ventricle, and a recent paper from the Mayo group for Alexander Ekbe look at what the effects of guideline medical therapy in patients with biventricular circulation systemic left ventricle, that they develop left ventricular dysfunction. And they show that if you treat these patients as standard with the standard therapy that you use for acquired heart disease, these patients improve the ejection fraction and they reduce the BNP. So if we can assume and we can say that if you have a congenital heart disease with a biventricular circulation and a systemic left ventricle, you can use guideline medical therapy and you're going to change the prognosis of these patients. Unfortunately, we cannot say the same when we talk about patients with systemic right ventricle. In this population, the evidence is little. So this is a table that I did for a book chapter last year, and you can see here all the studies we have done, randomized and not randomized, with different therapies in patients with systemic RV, and all of them has been either neutral or negative, apart from this study here that is the largest follow-up. Is patients with follow for 8 years with systemic RVs, that they showed a reduction in mortality and MACE, but when they look at which one was the preference individually of them, they didn't actually, the medication did not reduce mortality, but only MACE. And this is the only positive study we have so far. A more recent study, and what I call the real life study, because this is the group from the Brompton in London and the group from the Pompidou in Paris. They joined their population of systemic RVs, and they reported 360 patients with systemic RV, followed by for 7 years. Majority of them asymptomatic. Only a few of them have in class 3 or 4, and only 40% of them with medical therapy, but they conclude that neither ACE nor ARBs change their risk of having heart failure or their mortality. So, and this led to many people thinking that actually the guideline medical therapy does not work in patients with systemic RV. But I would like to stop here and look at this table with a little bit of more detail. So every time we talk about studies in heart failure and congenital heart disease, the heart failure doctors, complain about the numbers. I don't want to make this about the numbers, but it's true that we do not have the ability to have the thousands of patients of the heart failure studies in acquired heart disease. So the number is a problem, but I don't think it's the only problem why these studies have not shown benefit in this population. One of the main problems is that if you look at the patients that they are treated, majority of these studies have included patients that are actually quite well and not significantly symptomatic. If you look at the ejection fraction of the systemic right ventricle, actually, majority of the studies include patients with a quite good ejection fraction for a systemic RV. So 40–45% for a systemic RV is not a bad ejection fraction, which seems that we are trying to prove something in patients that have a quite good ventricle and no many symptoms. And what we try to prove is that's another criticism that I have about these studies. The endpoint that we try to prove in majority of the studies is reduction in volume in a quite short period of time. I don't think that if we had tried to do the same study in acquired heart disease, if the treatment reduced the volume of the LV in this given time, I don't think we will be able to prove that as an endpoint. So we might have to change. And I'm not saying that I know the answer to this question, but or to this comment, but I probably have to change what endpoints we are looking at when defining heart failure and congenital heart disease. And the last but not least, a comment that I have these studies, as I said, we have not enough patients for the studies, and therefore we try to combine patients with systemic right ventricle, those with DTGA or master ascending repair, and LTGA or CCTGA, in order to increase the number of patients. But we have already seen in a previous slide that physiologically these patients are different. And if you are treating the patients with different physiology, you cannot expect that the conclusion that you're going to obtain any conclusion because they behave differently. So probably what I say that we can tell with the evidence we have is we don't know if the medication works. I don't think we have evidence to say that doesn't work, but we can say that we don't know. And probably we have to start to think, when we think about studying these patients, with the concept that the right ventricle is different. And that sounds like an obvious statement, but I think we are used to understand that the right ventricle is different from the embryological point of view. So all of us know that the RV comes from the secondary heart field instead of the primary heart field. All of us would agree that the right ventricle is anatomically different and in the structure. I don't want to go into detail, but not many people would agree that actually the mechanism of adaptation to a pressure overload circulation, or that doesn't matter whether the right ventricle is in systemic position or subpulmonary position, the right ventricle does not adapt well to any pressure overload. We know that doesn't respond well, but the adaptation, I think, is what makes it different. And I think we have to consider this when we treat these patients, or when we're going to try to do any research about these patients. I'm not going to go into detail in this slide because it's a very busy slide, but I want to highlight which are these points where the RV, when in a high pressure circulation situation, behaves completely different than the LV. So the first problem is the metabolic adaptation. When you have a left ventricular failure, the ventricle has a mechanism to increase the production of ATP at the mitochondrial level and gives more energy to the myocytes. The RV doesn't have that kind of mechanism, and actually they end up losing production of energy, and that doesn't compensate well in a pressure overload situation. Another important factor is that the antioxidant enzymes that are well developed in the LV as response to heart failure, actually they are not activated in the in the failing RV, and therefore you have a higher increase of apoptosis in these patients. In this situation, sorry, they also have less ability to create new vessels, and there has a higher risk of ischemia. What I really think that is the most important thing is the response to the RAS activation. So while the AT2 receptors, the density of the AT2 receptors seems to be the same, and there's a lot of research about this, both in the RV and the LV, the angiotensin signaling pathway is downregulated in patients with failing RV. And even more importantly, the metabolic inactivation of ACE inhibitors, which happen in both ventricles, is more prominent in patients with a failing RV. And this leads to the hypothesis that if we have a downregulating system and a more inactivation of the ACE, should we use a higher dose of the ACE in this population to have the same effect? And this is a hypothetical question. I don't know the answer to that question, but what I want to highlight with this is that if we really want to prove if the medication works, whether the medication works or not in these patients, we have to change how we are approaching research in this population. If we move on to the most complex patients, which are the Fontan circulation, all of us know that in a patient with a normal circulation are patients that have two ventricles, and the LV pumps blood around the body, goes back to the RV, and to that age, sorry, the RV pumps blood to the lungs and goes back to the body, to the LA. And if you look at the hemodynamics, this patient is going to have a normal cardiac output, an ability to increase the cardiac output up to 5 times on exercise, a low CVP. The PA is going to be has pulsatility, which is important, and the saturation is normally more than 95%. If we try to represent what a Fontan circulation means, for those that are not familiar with a Fontan circulation, this is the circulation that, and any patient that is born with a single ventricle or inability to complete a biventricular circulation. And basically what we do is to bypass the venous return directly from the IVC, nowadays with an extra cardiac tube, directly to the pulmonary artery, and we connect the SVC directly to the pulmonary artery in a way that there is a single chamber that pumps blood to the body, comes back to the lungs, and the blood from the venous return to go through the lungs is a passive circulation, which depends pretty much of your inspiration. But in order to have the blood going through the lungs, you have to have a high CVP. And the problem with the Fontan circulation is that your cardiac output is reduced at the time that the Fontan is completed in a child. As soon as the surgeon removes the cross clamp, the cardiac output is already less than 100%. Also, when they try to exercise, they have the ability to increase cardiac output on exercise is significantly lower than a patient with a biventricular circulation. As I said, they live with a high CVP, is part of the condition, which gets worse over time, and they don't have pulsatility, and quite frequent they have a reduced saturation. So, of course, if you look at the evidence of treating patients with guideline medical therapy with a single ventricle, the evidence is even less, and the few studies we have, they say that the medication makes no difference. But of course, we are cardiologists, and when you have a patient in front of you, you have to do something. And this is these are two studies where they survey. On the left is in North America, and the right is from a European study, and they survey providers that look after patients with congenital heart disease. And they ask them, well, if you have a patient with a single ventricle, how did you treat them and why? And you can see here that majority of the centers would give these patients ACE inhibitors, despite of having no evidence to do so. And when they ask them, why do you treat them with ACE inhibitors? The majority of them, most of them, the indication would be having ventricular dysfunction of the single ventricle or AV valve regurgitation. So we do this because we have to do it. But as I said, the important thing in congenital heart disease when you treat patients is to understand the physiology. If we look at just stepping back and going and looking at what happened physiologically in the heart when we give afterload reduction medication in a biventricular circulation. So when you do an afterload, when you give an afterload reduction, the blood pressure is going to reduce because the SVR reduces and the blood pressure reduces. And in order to maintain the extra volume, in order to maintain the cardiac output, the only way of doing this is increasing the stroke volume. So there's no other way of maintaining the cardiac output when you do afterload reduction. This is very well represented here. You have a patient, if you reduce the afterload, the way of compensating is increasing stroke volume. What happened in the Fontan circulation? The Fontan circulation is another of one of those examples in congenital heart disease that is a preload dependent circulation and has the inability to increase stroke volume as time goes by and the left and the right atrial pressure increases, or the Fontan pressure, the CVP increases, their ability to increase stroke volume is even less. And when you give ACE inhibitors a patient with a failing Fontan, you actually might be in this situation where you reduce the SVR, and because they cannot compensate the stroke volume, you actually might reduce cardiac output. And this is one of the things that I've noticed over the years doing heart failure in these patients. Those patients that come to our to my heart failure clinic with a failing Fontan on ACE inhibitors, you stop the medication, which is the first thing I do, and they improve already the symptoms. Quite noticeable for them. Okay, you don't make them to run a marathon, but they notice the difference in exercise capacity, just reducing these inhibitors. If you use them very early when they are not failing, probably they don't notice the difference, but as soon as the Fontan is failing, having an ACE inhibitor actually might reduce your cardiac output. So again, the physiology, treating this patient is key when you decide what medication you're going to give to them. Of course, the treatments or the medications for patients with heart failure have increased significantly over the years, and this is the paradigm trial, which I'm not going to explain here. But of course, because we have nothing to offer to these patients, every time that we have a new drug, we try to see if this works in congenital heart disease patients too. And since the paradigm was published, several groups have published case reports or case series of patients treating with Entresto with different results. I think that the first 3 studies are not really very relevant because, as you can see here, they have mixed patients with systemic RV, systemic LV, or single ventricle, and we already said by now that the physiology is different. I don't think we can conclude very much from these 3 studies, but I really like the bottom one. It's a study that published from the group in Leuven, that they got 20 patients with systemic RVs, all of them with DDTAs, so mast tyrosine, so they did not mix different physiologies. They include patients that have a proper systemic RV dysfunction, and actually they were symptomatic. Majority of them have symptoms. After 6 months, they notice an improvement in NT-proBNP, an improvement in the systemic RV systolic function measured by GLS and fractional area change. And although they did not show an improvement in functional class, they showed an improvement in quality of life. So very little, small study, but this is what the numbers that we normally deal in congenital heart disease, and a study that might be promising the use of this medication in these ventricles, and actually those that we had the opportunity to use Entresto in systemic RVs, you can see in some patients a significant difference. More recently, the SGLT2 inhibitors came to the wall of heart failure. I think the SGLT2 inhibitor is going to be the aspirin of the 21st century. I think in a few years, all of us are going to have one of these. because they are good for almost every single organ. They're good for the heart, for the pancreas, for the kidneys, for the liver, for the brain. But at the heart level, they have multiple actions that all of you know, and I'm not going to go into detail in them, but there are some of the benefits of the SGLT2 inhibitors, which makes them a very appealing drug for patients with congenital heart disease, mainly for those that have a preload-dependent circulation. They have the ability of decreasing the RAS activation, which is very important to have a drug that does this in patients with systemic RVs. They have the ability to decrease the activation of the sympathetic nervous system, which is a good function to have. They reduce the pressure overload of the ventricle and reduce the myocardial fibrosis, which leads to a reverse the cardiac remodeling. And what I find very interesting, the SGLT2 inhibitors have the ability to increase the intracellular calcium and increase the energy of the myocytes. We said that in patients with systemic RV, they have no ability to increase the myocardial energetics. So having a drug that might have that effect might be very beneficial for this patient. Another factor that I think is very interesting, these patients, as all of you know, increase diuresis, but they do it with a greater reduction in the interstitial fluid compared with the intravascular volume. In patients that have a preload-dependent circulation, where we need to lose fluid, but not much from the intravascular volume, because that might reduce their cardiac output, having a drug that acts more at the interstitial level is very appealing. Of course, all of this is looking at the drug from the theoretical point of view, because we have no experience in congenital heart disease, but this is the only case report that was published at the beginning of last year. The same group that published the Entresto trial, they have this patient with CCTGA that had already a CRTD, had a tricuspid valve replacement with multiple admissions for heart failure on maximum dose of all the guideline medical therapy, including Entresto, and they were quite desperate, and that's what I asked the Anastasia why they try SGLT2 yesterday, because they were totally desperate with the patient was not a candidate for transplant, they didn't know what to do, and so they decided to treat the patient with the SGLT2. And although this is a single case and we have no more than this patient functional class improved after 4 months on the medical therapy. The very, very impressive how much the exercise capacity of the patient improved. The PQ2 increased from 32% to 33% to 56%. Ability and the watts that was able to do was more after 4 months. And looking at the systolic function of the ventricle with a strain and fractional area change, also this patient improved both. Again, this is a single case, and we cannot conclude anything from single case, but from the theoretical point of view, I think the SGLT2 are very appealing drugs to treating heart failure and congenital heart disease. My personal experience with SGLT2 is so far is been good, but I don't have enough longitudinal data to share with you and telling you that it's going to be the solution for our patients, but I think it's very, very appealing and very exciting what we can do with these drugs probably in the future. I didn't want to finish without mentioning the use of advanced therapies in this population. So every time we look, and doesn't matter the publication you use at the use of advanced therapies in patients with congenital heart disease that you have there in black compared to acquired heart diseases, there's no way that the congenital heart disease is going to win. So the use of advanced therapies is something that we normally don't think in congenital heart disease patients. And if we look even at the transplants in the recent study, the same study we showed before from Penn, that in the period of they assess these patients, actually instead of increasing the number of use of VADs or transplant, both of them reduce in this population. And what I want to point out here is that we are very scared of using VADs in congenital heart disease patients because probably they are known. And although we have not yet found the VAD that works in single ventricle, and this is data from the Intermax registry. The Intermax registry look at the VATs in patients with congenital heart disease and see what where the outcomes were. And you can see here that if you use VATs in patients with congenital heart disease and biventricular circulation, this is the graph I want you to focus, the long-term survival is exactly the same than the patients with non-congenital heart disease. And this includes patients with systemic right ventricle. So I think that it's important that we as a providers think that the ventricular assist devices are there and can be used safely in patients with congenital heart disease. Of course, I didn't want to finish without mentioning about transplant because we know that our patients have less chances overall to be transplanted, and of course depends on the center. Not the case in UCLA, but in many other centers, this population have less chances of getting transplanted. I will look at the 5 years mortality or survival of patients with transplants, and these are data from the ISHLT. You can see that patients with congenital heart disease actually have a much higher survival long-term than any other patients with any other non-congenital any other structural heart disease. So giving a heart to these patients you might pay a higher risk or at the beginning, at the time of transplant, but long-term, they're going to live longer, and therefore it's something that we have to consider. The million-dollar question is the timing for transplant, but that would be altogether a different talk. So I think we can say that if we look at the definition of heart failure from the guidelines, we can say that patients with congenital heart disease are at risk of heart failure since birth, because the risk of having heart failure is those patients that have a structural heart disease, and they are born with a structural heart disease, and this is the red line here. They are born with a structural heart disease. They get unwell. They have an operation. They get better. They get another heart failure. They have another operation or any kind of intervention that get better, and so on and so forth until the day that we get them into a transplant list. And when we get that to the transplant list, we know that actually the chances of getting transplanted is less, and the mortality of these patients on the waiting list is much higher than the non-congenital patients. So I think that having a condition that is increasing over time, and in a population with a higher mortality, that made us in Toronto to change the way we approach heart failure and congenital heart disease. So up to 8 years ago, before even my time in Toronto, every patient that was, so we were divided between the heart transplant and heart failure team and the congenital team. And every patient that was in the congenital clinic and have heart failure and needed a transplant assessment was referred to the heart transplant team. They would do all the assessments. Same with any external patient that was referred for transplant assessment was referred to the heart transplant team, and they did all the assessment of these patients. 8 years ago, we realized that actually this is not the way to do it, and the patient with heart failure should be in a specific heart failure clinic. And what we do, or what we have, is we are two of us, so Dr. Lucy Roach and myself, we have 2 heart failure clinics a week where we see all patients with heart failure and congenital heart disease that come. Majority of them come from our colleagues in the unit, but many of them also externally from another units that they are referred to us, not only for transplant evaluation. Sometimes it's just to manage their heart failure, but definitely all the transplant evaluations are done by us in the heart failure clinic, and we have the ownership of the patient. And we are the ones that discuss the patient with our congenital surgeons, with our transplant surgeons, and with the heart failure heart failure team, and all of us together make the final decision of when we decide to do a transplant. But the patient is staying with us in the heart failure clinic until the time of transplant. After, when it's transplanted, of course, goes to the transplant team. This is being very successful in the management of these patients. We have already almost 800 patients in the heart failure clinic, and it's growing. And that's actually the reason I moved to Toronto is just to expand this clinic, because this is what I did in London. I was the director of the heart failure service there, and this is going to be even worse over time because the number of patients with heart failure is only increasing. So to conclude, I can say that heart failure is common in patients with congenital heart disease, and is the leading cause of death in patients that after 40 years old. Different anatomy and physiology makes challenging the diagnosis of heart failure or to diagnose heart failure in congenital heart disease patients, but both anatomy and physiology should be considered when you're going to treat these patients. So you cannot just think about heart anatomically, but physiologically is more important. I think the VATS should be considered in patients with ACSD with biventricular heart and heart failure. In the univentricular heart, although there are groups that do VATS, I don't think we have that yet well developed, but something that is coming and needed. The long-term survival after heart transplant is better in congenital heart disease patients, and therefore they should even have or have the chance of having a heart transplant. I always recommend that if you have an ACSD heart failure dedicated clinic, early referral is recommended for these patients because it's better to refer them before even transplant is considered, when we might tune them with intervention or medical therapy or whatever we use to tune them, than referring them when it's too late and we might not be able to offer a transplant. So with this, I finish. And before finishing, just following the comment that Jamil did, we have in Toronto, our Toronto International Rounds, which are educational rounds that happen every other Friday of the month, where you can, as Jamil said, we invite speakers all over the world to talk about hot topics in congenital heart disease. This morning at 5 o'clock in the morning, I was chairing the rounds in Toronto, and we talk about nomenclature in frontal circulation, which are normally topics that are important. So if you want to join the rounds, there are several ways. So the rounds are posted in Twitter. So this is my Twitter account where I post the rounds every Wednesday, when the Wednesday before of the rounds. But otherwise, you can also email, and this is ACSD, it's Toronto ACSD at uhn.ca, and that is our email, and they can you can join the distribution list, and you will get an email with a link on Thursdays every week that we have the round. So either Twitter account or Toronto ACSD at uhn.ca. Thank you very much. I'm happy to take any questions.
Thank you so much for that, Rafa. That was great. Really enjoyed it. And happy to take questions from the audience, but maybe I can start with a question for you, Rafa. And that is, if you can give us some of your thoughts and your approach to right ventricular volume overload lesions, not in the systemic position, but in patients who have pulmonary valve regurgitation and tricuspid valve regurgitation, and therapies that you would use for those patients, and timing for valvular interventions. I'm currently at the Medtronic implanters meeting, and there's all sorts of debates going on as to, should the thresholds for pulmonary valve interventions be altered in the current era of transcatheter versus surgical valves, et cetera. And I'd love to hear your thoughts and your approach in Toronto to this particular issue regarding RV volume overload.
So I think that's the $1 million question, Jamil. So I think that just gonna divide your question into in what pulmonary valve, tricuspid valve are combined. So if you look at looking at the pulmonary valve, I think the volumes are not all. So volumes is one thing. I think the function of the ventricle is as important as the volume. So I'm of the idea that, and in Toronto, I'm gonna be fully honest with you, we don't have even a homogeneous approach. So as you know, Toronto is well known for operating these patients quite late. And I'm of the idea that when your ventricles start to dilate, and your end systolic volume is already large, that means that your myocardium is not able to contract. And that is for me the timing to do that PVR. And the reason is to keep the RV function in the future for these patients, because it's true that people say, well, you don't have data in mortality in these patients. That's true, but we do have data that if you develop right heart failure, your survival is less. And if you don't preserve the ventricle, then your risk of developing heart failure is going to be higher over time. So in a patient that is asymptomatic and systolic and systolic volume reach what the guidelines cutoff is, and that volume is being reproduced in several papers, and I think it's a higher risk that the one that have a large diastolic volume. You have a combined lesion with tricuspid and pulmonary valve regurgitation. Again, if your ejection fraction of the RV is okay, probably you're going to handle it. But as soon as your function goes down, even if the patient is asymptomatic, I'm more prone to fix the valves, because otherwise, is that what we do with aortic regurgitation anyway? Seems that it's okay to operate a patient with an AR because the ventricle is only 60, but the ejection fraction is 45. But it's not okay to operate somebody with a PVR, with a PR and tricuspid valve regurgitation because the volume is not 160. So, but the RV function is 40%, when before was 55%. So I think the RV function needs to drive the decision, and that's not even in the guidelines, as we do in the left-sided lesions. And since that we are very comfortable with the left side, but seems that we have to prove that volume, that otherwise we are not comfortable with the replacement. So that's my approach. In terms of the combined lesions and the RV function is the approach in Toronto too. As long as the RV shows signs of deterioration, that's a early replacement in the combined lesions for sure.
Great, thank you for that, Rafa. And I think we also have a question from Dr. Lurie.
Yes.
Yes. You have texted me. Go ahead, Gentian.
Thanks, Jamil. Thanks, Dr. Alonso, for the great talk. I mean, here we're fortunate we have a very robust advanced heart failure and transplant group that we work closely with. But my question is also with regard to another group of patients that we seem to see more and more. And here we have also a very robust cardio-oncology group led by Dr. Yang, Eric Yang, who I believe is also online. And we seem to see also in our adult congenital heart disease population patients who, for one reason or another, develop different types of malignancies that put them at a risk for heart failure. And my question is, like, what has your experience been in Toronto? And there is a particular unique approach to this. Certainly, it's like it appears to be a field that almost nothing is known about in our patient population.
So that I think that's the answer to the question. Nothing is known. I can tell you, I had a couple of patients. Well, in Toronto, actually, a couple of patients in London too. In Toronto, we have a very strong cardio-oncology group as well, and they take care of these patients. But to be honest, they treat them with the same drugs that they use for the non-congenital patients, even in patients with single ventricle. And I know that I said that ACE inhibitors in single ventricle might be a problem. The good thing is, the good thing is never a good thing to have a tumor, but majority of these patients that develop a tumor with single ventricle are young, and their fontans are okay. So in that situation where your fontan is working, giving ACE inhibitors, they do not have an impact in their cardiac output, but they might, whatever it's worth, might have a protection of the myocardium, which we don't know. So the agreement that we have is just treat them as you would treat any other patient that have a non-congenital heart disease, and probably more in the single ventricles be more proactive. The experience I have is the number is 3. 3 of them were treating with ACE inhibitors and beta blockers, and 3 of them went through. But equally, if we didn't treat them, we don't know what would happen to the ventricle. So, the experience is, I do not have much experience with ones that didn't treat, because, in my area already the cardio-oncology was quite a thing since I do congenital heart disease. And even in London, when I had one in London, the one that had in London was treated throughout the whole chemotherapy, and the 2 in Toronto, they were treated through the chemotherapy. 3 of them were 3 lymphomas. They are cured, and One of them even had a bone marrow transplant, and they are cured and well. But I cannot tell you if it's the right thing. I don't know. I cannot tell you if they had gone through without that medication. I think that makes sense to treat them as long as their fontan is stable. If it's a patient with a biventricular circulation, I think this for me would be a non-brainer. I would treat them as patients with non-congenital heart disease.
Thank you.
Doesn't look like anybody else has put their hand up. So if no one else has any questions, I do have one final question for you, Dr. Alonso. And this one's a bit of a difficult one because I don't think we know how to get this one right yet, which is when to involve the palliative care service in the care of our ACHD patients. Oftentimes it seems that we do it too late, but sometimes bringing it up earlier, especially in a younger population, tends to be difficult. Exact prognostication tends to be difficult in our population, and oftentimes we lean towards doing a lot of invasive things and transplants and trying to do whatever we can and eventually get to the palliative care option in a few patients. And I would love to hear your approach in Toronto in your heart failure clinic to this difficult issue.
I'm glad that you asked me that question, Jamil, because we we have a dedicated palliative care staff for the program. So there's something that we opened this year. And that person, we refer patients to her when we decide that it's time. But with the patients that go for transplant, we have our approach is every patient that is in the transplant assessment sees the palliative care patient, the attending. So they are referred to palliative care at the time of transplant assessment, and the palliative care is very helpful even to work with them about advanced directives, to discuss with them the option of not having a transplant, how it can be alive with chronic heart failure. So it's definitely a part of the protocol is they have to see palliative care, and it's the same person all the time. Every patient that we decided not to transplant and we know that it's going to be palliative route, although the patient might be stable right now, we refer to palliative care already, and we involve them very early. The difficult ones is the ones that you have not yet made the decision. No, so but if in those that you already have got to the point, okay, is a transplant an option? If it's an option and you assess for transplant, is part of the assessment is seeing a palliative care. And if this patient has heart failure and is not transplantable, goes to palliative care very, very early. This is something we've been doing for a year. And the feedback that you have from the patients is spectacular. So they are really happy to meet the palliative care, to be able to discuss with them the goals of care, what is going to happen with them when they get sick, and they can make those decisions when they are well. And the palliative care continue to follow them, and when they need their help, they just put their medication. But we have a very, very positive feedback involving palliative care quite early in the journey.
Okay, well, thank you for that very enlightening talk and for everything that you're doing for this field and all your accomplishments. Thank you for coming to visit us at UCLA. Dr. Alonso, it's been a pleasure. And thank you everybody for joining.
Thank you for having me. Bye-bye. Thank you.
Thank you.
Bye.